ET3, or Emergency Triage Treat and Transport. Get it? Because there's a E in emergency, and then there's three T's. So ET3. Yeah, not the most creative name. Anyway, for those of you unfamiliar with this program, it is a Centers for Medicare and Medicaid Services pilot or test program that is set to start at the beginning of next year and run for the next 5 years. It's been in the news a little bit this year after its announcement, but it hasn't really been explained much beyond being a new payment model. So I figured I would do an episode on exactly what it is, some things you should probably know about it, and where I think it'll end up taking us. But first, let's make one thing perfectly clear. This program is designed to save Medicare money. They do point out that it might help make EMS agencies more efficient, but that's really more of a side effect, and the end goal has and will always be to save money. Now then, on to the key points. So, number 1, the program has 3 so-called parts or innovations. One is the medical triage line, which is basically an EMD program as far as I can tell. The second is the transport to alternate destination option, which does not have to be an urgent care center. And lastly is the treatment in place option, which should be pretty self-explanatory. And not all of these have to be implemented in order to be eligible for the program. There is a stipulation that you have at least one form of either treat in place or alternate destination option available 24/7. Which can be done with a combination of the two if needed. Second point, the program will not provide grant funds, at least not for anything related to the treatment in place option and alternate transport options. But there is a chance to get some assistance with setting up a medical triage line after the NOFO, or Notice of Funding Opportunity, is published. The third key point is that this program will only apply to Medicare fee-for-service beneficiaries. So if you transport someone who does not fall in that category to an alternate destination, or treat them in place, then you may not receive reimbursement for it, unless the insurance they have is also supporting this type of service. Which, to be fair, some of them are. But they're pretty far in between. The fourth point is that the CMS is only going to be reimbursing ambulance responses, meaning that first response units such as engines in QRVs are not eligible for reimbursement under this program. Even on the treat in place option, an ambulance is still required to be there in order to be reimbursed. They also do not plan to reimburse community paramedicine program visits or other scheduled appointment visits either. The fifth point, the CMS does not consider EMTs and paramedics qualified healthcare professionals, at least not ones that can treat on scene. This is important because in order to get reimbursed for the treatment in place part of the model, CMS clearly states that the patient must be assessed through either telemedicine or in person by a qualified healthcare professional, which is, in their mind, a NP, PA, or a doctor. This means that refusals or treat and release incidents by paramedics only are not eligible for reimbursement under this model. The sixth point, the CMS is not altering reimbursement rates, at least not yet. 3 years into the model, it seems that they may be willing to adjust the reimbursement rate, probably based off the data of the first 3 years, but from the start, there will be no adjustments. The seventh point is that the CMS will not reimburse multiple facets of the model from one incident. What this means is that CMS will not pay a telehealth provider or an EMS crew for treat in place if he determines that the patient needs to be transported to an alternate destination or ER. They also pointed out that the reason for this is if they require an ER or alternate destination, then a telehealth provider should probably never have been considered in the first place, and that they plan to monitor participants for instances of under-triaging, which sounded a little more threatening and aggressive than it really needed to. It is worth noting that they will reimburse the EMS crew for transport in this instance, provided the patient meets the requirements for ambulance transport, which brings me to my final point. Point number 8. Medical necessity rules and EMTALA rules still apply, and if patients don't meet them, then the ambulance still does not get reimbursed. What this means is that patients still need to meet the needs for ambulance transportation even if going to an alternate care destination. And with EMTALA remaining in effect and unaltered, means that if the patient still wants to go to the ER, Even if it's not medically necessary or they don't have a reason to go by ambulance, they still go to the ER. So, is all this really good? Meh. On one hand, it is good that EMS is being included in these discussions about how to make healthcare more efficient. But on the other hand, I still feel like EMS is getting the short end of the stick here. Hospitals will get some relief as they will have less patients being brought to their ERs as we transport to more alternate destinations, which overall for the healthcare system is cheaper. But ambulances are still required to run these calls, which in turn requires crews. And I honestly don't think the standard reimbursement rate for Medicare fee-for-service patients is going to be enough of a financial incentive for EMS systems to overhaul themselves, especially if the majority of their patients use Medicaid or private insurance that does not offer these as options. Another issue I see is telehealth being used more as a consult for EMS providers than a tool to actually treat in place, such as using a telehealth doctor to convince a patient that it is not medically necessary for her to go by ambulance to the hospital for her abnormal labs. And I'm assuming that the way it's currently written, telehealth wouldn't get reimbursed for that either, and EMS won't get reimbursed whether she goes by ambulance or by herself. So, honestly, what I think is this program kind of screws us financially, but it will cut down on ER overcrowding and ultimately end up costing the patient less, I hope. I truly hope that in a few years I'm either wrong about this or Medicare realizes the issues on their end and tries to fix them. I also hope that private insurance companies and Medicaid coverage changes to allow these alternate options for the sake of patients and ourselves. But for now, I guess we'll just have to wait and see.